Hello everybody. So my name is Cynthia. I'm one of the registered nurses here at the Richardson Hospital. I'm going to be talking today about oral health care, what we do basically here. So I'm going to be exploring that with you today. So the context of my presentation today, we're going to be talking about dysphagia. We know that dysphagia patients are at higher risk of developing what we call aspiration pneumonia. This is when they inhale food particles or, just something that's not supposed to go into the lungs, and they develop pneumonia. It's been proven that rigorous oral care is known to reduce the risks of aspiration pneumonia. The objectives of our oral hygiene plan here is to ensure integration of the best practices related to oral hygiene. We want to maximize the safety of feeding and swallowing activities of our patients. In this way, we're able to reduce risks of complications from aspiration and also to maximize client independence with activities related to oral hygiene. So basically, we have three essential steps in this program. The first one is the oral health screening, which is done by the RN upon admission. We have 3 days to do that. We also have what we call an oral health assessment, which, as it says, it assesses what the presentation of the patient's oral health is. We then go ahead and complete an oral hygiene plan, which is then communicated to the PABs, who will carry out the oral hygiene care of the patient. Now, what is oral health screening? So basically, the registered nurse upon admission would look at the following elements. There are 3 main criteria that we look at. Basically, we look at a patient who's known for a high risk of aspiration. Mostly these are patients who originally had aspiration pneumonia in acute care. We also look at patients who are nothing by mouth or NPO. These are usually the patients on gavage or PEG feedings. Usually we'll see a patient who has a white coating on the tongue. These are elements that we look out for. If any single one of these are present, we do what we call an oral health assessment, and we know that this patient is at risk of poor oral health, and we then need to really devise a plan to take care of their oral health. So that form there is what we use. It has the different elements. It looks at the patient's tongue, lips, and other elements of the buccal cavity. We tick it, and it guides us to our plan of how we're going to be looking after the oral hygiene. Now, on this paper here, we look at things such as the patient's independency. How much are they doing in terms of brushing their own teeth? Do they need supervision? Do they have dentures? Do they have missing teeth? Are they eating? So we look at all that. And on this oral hygiene plan, once we've completed it, it gives us a guide as to what to instruct our PABs and the rest of the team members on how we're going to be caring for this patient's oral hygiene. So as we can see, the PAB would then implement the oral hygiene care plan that would have been communicated by the RN. It is the PAB's responsibility to communicate with the RN or the LPN whatever changes or difficulties they face while performing the oral hygiene care plan. Such difficulties could be maybe a patient who seems not to be able to withhold from sucking on the sponge, and they're actually sucking onto it, and they're at high risk for maybe aspiration at that point. So such things should be communicated to the RN, who will then speak to maybe the SLP and further evaluate the patient. We also focus on client and family education. Here at the Richardson, these are rehab patients. We do want them to be as independent as possible. So all team members contribute to the client and family education based on the oral hygiene care plan. So as we identify knowledge deficits in oral hygiene, we always try to teach the client and the family members in order to support their independence in taking care of their oral health. So this diagram shows you that the patient is at the core, is at the center of what we do here. So as you can see, we have different disciplines. We have nursing there. We have our PABs, our dietitian, the doctors and the pharmacists, the speech and language pathologists, and the occupational therapy. Oral hygiene may seem like something that we all do every day, which we do, but it is a very important element, and as such, it is important that all team members are involved. For example, your patient might have the ability, well, rather the knowledge on how to brush their teeth, but maybe because they've had a stroke and they've lost dexterity, maybe in their right hand, you would then consult with occupational therapist to make the adaptive aids or strategies to help this patient to be able to brush their own teeth independently. So let's look at the different roles and responsibility of the different team members. Now, as I had mentioned briefly previously, the RN screens all newly admitted patients within 72 hours upon admission. So we would have already looked at the risk of complications. The RN also completes an oral health assessment tool for patients who have been identified to be of high risk that will compromise their oral health. We also complete an oral health care plan, and this ensures that the PAB is able to provide the continuity of care in terms of taking care of the patient's oral care. As always, during our rounds, which we are interdisciplinary rounds, it is the RN's responsibility also to identify goals in oral hygiene. For example, if my patient presents with a white coating on the tongue, I should be able to collaborate with the doctor and see what kind of medications can be used to take care of that. And I should be able to say, within a week, the patient's tongue should show a nice pink moist tongue or something to that effect anyway. So goals should always be communicated and identified in the rounds booklet. We look at now the licensed practical nurse. Now, she, of course, as we know, our LPNs work closely with the RNs, contributing data to the RN's oral health assessment. As I mentioned before, our PABs also play a crucial role in that they're the ones who are doing the actual brushing of the teeth. And as such, it's important to communicate with the RN and the LPN of any challenges, complications, or changes that they notice while they're caring for the patient. The SLP, or the speech and language pathologist. Now, this team member collaborates and supports the team on issues related to oral hygiene, as you can imagine. We often consult our SLPs, to provide opinions on certain challenges that we face, especially with dysphagic patients or patients with aphasia. So they also, of course, let's say with somebody who's on a gavage, they would then contribute to any diet progression. So maybe my patient is on honey thickened liquid. They would then assess them and look at the dietary progressions according to their oral hygiene status. OT, as I said, is occupational therapy. They offer the therapeutic interventions with the view of maximizing patients' independence. Like the example I gave with a patient who's lost dexterity in their hand, our occupational therapists would then be able to provide tools to assist the patient in brushing their own teeth. We also have the dietitian. Our dietitian screens during initial clinical nutrition assessment and flags to the RN if there are any issues observed. They also reinforce the importance of adequate oral hygiene and encourage family and staff, as well as the client, to follow the care plan that's been prescribed by the RN. They also implement diet progression based on oral hygiene status. So, example, a patient who presents with very bad teeth, they haven't been looking after their teeth, and their dentition is such that they're limited to the types or textures of food they could eat. Now, this puts them at risk for, nutritional deficits. So, in that sense, we do consult closely with the dietitian to implement diet progression based on that oral hygiene status that the patient presents with. The physician or the MD will evaluate, identify, and treat any underlying causes contributing to oral hygiene issues identified. For example, a patient who's been on antibiotics for a long while may develop oral thrush, right? The MD would then probably, prescribe an antifungal rinse or something to treat that. And in that sense, then, we're supporting the patient's health and, most importantly, their oral health. And as always, if the MD sees a need for a consultation with dentistry, he will make that consultation for the patient. Now, what is the role of the client and the family? It is very important when caring for patients to recognize that in as much as we would like to do for them, it's important for us to empower them. In this sense, we want the client and the family to participate and collaborate in the development of the care plan, as well as to follow and share in its implementation, keeping in mind, of course, the safety of the patient. So if the patient still needs help with brushing because they're still at that point where they're at risk of swallowing the water instead of just swishing and spitting, then at that point, then the strategies we would use is maybe to have an LPN or an RN or a PAB to assist the patient while still teaching them what needs to be done. So as I mentioned, just one drug class, which is antibiotics. Many other different drug classes do affect or have an impact on oral health. So I have the list here. I'm not going to go through all of them. But one important one that we meet a lot is, example, I said antibiotics, but also bronchodilators. We do know that we do have a lot of patients who have puffers, and one of the things with some of the puffers is that we should be teaching and ensuring that the patient rinses their mouth after administering this bronchodilator. So such issues are we like to address that with our patients. So we do have our algorithm here. Basically, this is our protocol. This is something that helps us and guides us in how to care for our patients after we've screened them and developed an oral care plan. When patients are admitted here at the Julius Richardson, we give them what we call the welcome booklet. In this booklet, it has a checklist for patients. It's an easy go-to place. It basically states what some of the required items. Right there at the top of the list, you'll see toothbrush, toothpaste, dental floss, mouthwash, denture adhesive, and cleaner. All this, of course, to take care of the patient's oral hygiene. Now, why do we brush our teeth? So it may seem like a silly question, but it's a very pertinent question. Regular and thorough brushing removes the plaque that causes gum disease and decay. Rigorous oral care has been shown to reduce the risks of aspiration pneumonia. I mean, if you aspirate it on your own saliva, which is fairly clean, good. But if your oral hygiene is compromised and you have all kinds of bacteria, I mean, we always do have bacteria in our mouths, that's known, but poor oral hygiene has been linked to the risk of aspiration pneumonia. And the thing about it is we've seen it that aspiration pneumonia does happen during rehab, and patients end up being sent out to the ER. So it is quite a serious issue. So how do we perform oral hygiene? So with our natural teeth, we use toothbrushes, not the pink or the blue sponge. Those are really just for moistening the mouth. Dentures, we remove them and we clean them in the correct solvent. How do we prevent bacteria buildup? We also brush our tongue and our teeth. So that's one thing that is often forgotten. The tongue needs to be brushed as well. So just general guidelines, we should be brushing our teeth at a 45-degree angle to our teeth in nice, gentle circular motions. We should be using a soft brush with rounded bristles, and good brushing should be done on every surface of the tooth. The chewing surface, the cheek, the sides, the tongue, and really we should be spending 2 to 3 minutes performing our oral hygiene. So what are the key points in oral care? The toothbrush is the best way to clean the teeth. Foam swabs really should be reserved for just moistening the mouth, especially for our NPO patients. We do have suction toothbrushes, which are available with the assistant head nurses on both floors. We also have a list of oral care items noted in our welcome booklet, which is given on admission. So every single member of the team can always reinforce this, especially in the first couple of days upon admission, well, after admission, we could always reinforce and make sure when the family comes to visit, check the drawers. Does the patient have a toothbrush? Don't be ashamed to ask for a toothbrush. It is essential for the patient's oral hygiene. And if unavailable, absolutely, you can always collaborate with your assistant head nurse. She has a supply for the patients. So we do have some measures in place to help us to just remind us of our high-risk patients. So we have hospital bracelets. Here at the Richardson, our client ID bracelet is wide, but the blue dysphagia bracelet, the dysphagia bracelet rather, is blue. We don't put any name or any texture on that bracelet. It's to remain just plain white with blue around it. Any questions we have in terms of texture or whatever else regarding the patient can always be found in the patient's Cardex, but we certainly just keep that blue bracelet so we know amongst each other as interdisciplinary team what that means right away. Well, that's all I have today. Did anyone have any questions regarding my presentation? Okay, perfect. Thank you for coming.